Hello, friends. It's time for another radio shot of the day, and today we'll be talking about a case of 52-year-old gentleman who came to us with pain abdomen, altered bowel habits, anemia, and a raised fecal calprotectin. Now, for those of you who don't know what is fecal calprotectin, it is a very sensitive marker for inflammation in gastrointestinal tract and is specifically raised in inflammatory bowel diseases like Crohn's disease. So the clinician was having a high suspicion of Crohn's disease, and so the patient was sent to us for a CT enterography. Now let's have a look at the CT ectrography images. Now this is a video which is going to show you the CT images of the patient from cranial to caudal. So let's have a look at it. What you can see, I think all of you would be able to see that there is something gone wrong with the bowel, the most apparent thing. But there are so many things that are hidden in this video. So let's try to decipher all of them one by one. So now I'm playing the video again from top to bottom. I can see some dilatation of bowel loops. I hope everybody of you would agree with me that there is dilatation here, everywhere. And if I ask you which loops are dilated, then obviously you can see volvuli convolutus in all the dilated cut loops. So this is basically nothing but the jejunal loop dilatation. We have jejunal loop dilatation for sure. Apart from that, we can also see that there is something gone wrong with the mesentery here. We can see extensive haze in the mesentery. We can see all these prominent vessels in the mesentery. And this is not all. We can see some plumpy looking lymph nodes in the mesentery as well. Last but not the least, the root cause of all problems is lying here. And what is the root cause? We can see that there is bowel wall thickening, and this bowel wall thickening is affecting very long segment of the bowel. It is involving almost entire mid or distal ileum. And the cause of obstruction in this case is basically nothing but this thickened bowel, because here is where the zone of transition is following. If you see carefully, let me play the video, you can see that till here the loop of gut is dilated, but when this loop of gut comes in contact with this loop of gut comes in contact here with the other loop, and then when we look at this loop coming here, it again shows a gradual transition. So we do have a bowel obstruction. The cause of bowel obstruction is an abnormal bowel wall thickening. This is not yet over. We will need to see this particular case from a different angle, and this different angle is going to be the coronal plane. So from the cornel plane, again, I want you to have a look at these images. You can see there is significant dilatation of the gut loops, and this dilatation of gut loops is predominantly the jejunal loops. And we can also clearly see that there is bowel wall thickening affecting the right-sided gut loop. So let me play this video again for you, and I hope all of you would be able to see the dilatation here, everywhere. And the root cause of this dilatation is lying here, where we can see that there is long segment thickening of the bowel wall. Along with it, we can also see some mesenteric changes. So what is this particular disease? How does it behave? What we need to report when we are looking at this particular pathology? And how can we help clinicians in the ultimate outcome of the patients? This is what we're going to learn in this session. So now we'll be looking at the most important and representative findings from our case, and we can look at it through this coronary formatted image. The reason why I'm showing you this coronary formatted image is because this image is showing you the most important findings which will help us in making a diagnosis in our case. So if you see carefully, there are two areas of interest, two very prominent abnormalities, one on the right side and one on the left side. I think everybody of you will be able to pick it up. Now, what is the pathology? First, let's talk about the right side. On the right side, I think everybody of you would be able to pick up that there is a bowel wall which is thickened. So there is a bowel wall thickening here, and we already discussed that this is a ileal loop which is thickened. So there is bowel wall thickening, number one. Then let's come to the second part. Second part is located on the left side of the abdomen. On the left side of the abdomen, we can see that the loops are dilated. And what are these loops? These loops are showing volvuli convolutus. So they are nothing but this is jejunal loop. So the second important finding that we can see from our case is jejunal loop dilatation. The question that directly comes to our mind is, why is this loop getting dilated? Because there is some form of obstruction. Why can obstruction occur in Crohn's disease? Because if you see this gut loop on the right side carefully, let me just magnify it for you. You can see that the lumen appears narrowed. The bowel has thickened to such an extent that it has caused luminal narrowing, and this is the reason why there is proximal dilatation of the jejunal loops. Now, there is one more important finding which is hidden in this case, and this is the reason why I wanted you to have a look at this case. This is this. What is it? Here you can see that there are multiple prominent linear vessels which are supplying the thickened loop of gut. Now, what are these vessels which are present within the mesentery and supply the gut? I hope all of you already know this. These are called as vasa recta. So the third important finding is prominent vasa recta. prominent vasa recta. And the appearance of the vasa recta, which have become prominent, is just like the teeth of a comb. If you make a comb like this, it just looks like a teeth of a comb. And this is why there is a famous sign which you might already be knowing about, is called as Coombs sign, which is associated with this particular disease entity. So from this particular image, we can at least pick out these three important findings. Now let's try to decipher them. Let's try to dissect them a bit. First of all, let's talk about bowel wall thickening. Let me clear this up for you. So when we talk about bowel wall thickening, let me again magnify it for you. We describe a thickened bowel loop under various headings. First of all, we talk about the length of involvement. So you can see that their involvement is definitely beyond 5 centimeter. A gut loop more than 5 centimeter length is being involved. So this is basically a bowel wall thickening which is involving a long segment of bowel. It is not a short segment or a focal mural thickening. Second important thing that we also describe is whether the bowel wall thickening is concentric, that is, it is symmetric or it is asymmetric. So again, I want you to take the help of this particular image and tell me whether the entire bowel loop appears thickened or it's more of an asymmetric involvement. So here we can see that almost entire circumference of the bowel loop is thickened. So the second part is solved. We are dealing with a case of a long segment bowel wall thickening, which is associated with concentric thickened of the thickening of the bowel loop. Last but not the least, I want you to have a look at the enhancement pattern as well. So when we talk about the enhancement pattern, do you think that the entire bowel loop is enhancing as a whole, or do you think that there is some stratification, there is some mural change or gut signature being seen? Yes, clearly we can see that the internal layer, and this internal layer is nothing but the mucosa, is hyper enhancing as compared to rest of the bowel wall, which is not showing as evident enhancement. So this pattern of enhancement has been called as layered pattern of enhancement or mural stratification, in which one particular wall of the bowel or one particular segment of the bowel wall is going to show you a higher degree of enhancement as compared to the rest of the bowel wall. So we are dealing with a case of a long segment bowel wall thickening. The bowel wall thickening is more so concentric and it is showing a layered pattern of enhancement. One more important thing that we also describe is the thickness of bowel wall. So when we talk about the thickness of the bowel wall, you can just measure it, and in this case, it was coming around 5 mm. So you have to write this because again, in various inflammatory bowel diseases, you will find that there is a grading which is given upon the level of the bowel wall thickening, upon the severity of the bowel wall thickening, depending upon the objective criteria of what is the bowel wall thickness. So right now we can actually make out all these findings from this particular case. Now let's go ahead and look at the most important findings of this case from the axial view. So in this Excel view, again, I'm just going to magnify it. You can see that there is a ball wall thickening which is present all over here, and this ball wall thickening is more so concentric. Again, we can just reiterate the fact that we're dealing with a concentric mural thickening of the bowel wall. And when we talk about the enhancement pattern, again, you can see, let me magnify it, the inner layer of the bowel is enhancing more as compared to the outer layer of the bowel. So this type of enhancement pattern is called as layered pattern of enhancement. The other findings like the mesenteric changes can easily be seen here, but the reason why I wanted you to have a look at these images is I want you to have a look at this thing. These are nothing but lymph nodes. Mind you, in cases of all inflammatory bowel diseases, it's not necessary that we're dealing with the Crohn's disease. It's not necessary that we're dealing with a case of tuberculosis. We can get lymph nodal involvement. We can get lymph node enlargement. So if you get a lymph node enlargement in setting of a concentric mural bowel wall thickening, you're again left with two differentials. First of them is TB. The second one is Crohn's. Now, I want you to have a look at all these images and tell me whether we're dealing with a case of tuberculosis or whether we're dealing with a case of Crohn's. And at the end of the session, I hope we'll be in a better shape to answer, and then I'll be coming to this question all over again. Now, I want you to have a look at another very important representative image from the same case. And if you see carefully, I'm not only showing you the image of the CT here, but I'm also showing you an image of a sari. So what have these two images got to do with each other, and what is the resemblance between the two? Let's try to decipher. So this is the axial CT image of the patient, and in this axial CT image of the patient, I hope few of you might be able to see the pathology. Now, this is a different image from the same case that we've seen previously. What do we see here? I want you to focus on this particular section. So I hope here in this image, if I just magnify it, you might be able to pick up the pathology. You can say that there is some bowel wall thickening which is occurring along the lateral aspect of the bowel. Now, this type of bowel thickening is not symmetric. It is not diffuse. This bowel thickening is more asymmetric, and it is different from the type of bowel wall thickening that we saw previously, which was concentric. Here, what we're seeing is an asymmetric mural thickening. So I can call it an asymmetric wall thickening, and this is also present in the region of the distal ileum. If you see carefully about the enhancement pattern that I was talking before, then again, I think you can appreciate the pattern of enhancement being layered or non-layered. I hope everybody of you would be able to call it layered. We can see there is hyper enhancement of the mucosa, and the rest of the bowel is enhancing, but it is not enhancing much. So this is the thickened bowel, but the mucosa is enhancing maximum. So again, we have a layered pattern of enhancement. The second important thing is layered pattern of enhancement. These are the two important findings, but this is something that we saw previously also. So what is special with this image and what has it got to do with this sari? So I want you to now have a look at the other aspect of the bowel. The other aspect, or the outer edge, or you can say the mesenteric edge of the bowel, is showing no abnormal bowel thickening. Rather, it appears to be folded on its surface. Now, why is this folding occurring? Try to understand this with an example of sari. Now, if you have a bowel wall which is normal, so this is a normal bowel. Now, if you have asymmetric bowel wall thickening, which involves only one segment of the bowel, then over a period of time, there will be fibrosis, which will result in foreshortening of only one aspect of the bowel. So once this bowel wall becomes thickened and it becomes foreshortened, this anti-mesenteric aspect of bowel will become large enough or longer as compared to the mesenteric aspect. And as a result, it will unfold itself just like the pleats of sari are holding. This phenomena, which occurs in inflammatory bowel disease, in which there is asymmetric mural thickening, and because of fibrosis of the wall, there is overhanging of the mesenteric aspect of the bowel, is called as formation of pseudo saculations or pseudo diverticulations. And this is a very, very important phenomena or a feature of Crohn's disease. So now we have come to the conclusion that we're dealing with an inflammatory bowel disease, and this disease is Crohn's disease. Now we've made the diagnosis. Let us just quickly devise what are the things which happen in Crohn's disease and how do we see them in radiology. So as we know that Crohn's disease is an inflammatory bowel disease, IBD, and the most common site of affection of Crohn's is the distal ileum. What we can get in Crohn's in the initial phase, the Crohn's disease starts the mucosal disease and then it keeps on involving all layers of the bowel wall, which we already talked about. The most common involvement is in form of bowel wall thickening. So this is what we can get. We can get a diffuse thickening, a concentric thickening, but this is the more common way in which we have an asymmetric mural thickening affecting the mesenteric aspect. Now this is important. The mesenteric aspect of the bowel wall is affected more as compared to the anti-mesenteric aspect. If we do a CD scan at this particular stage, we can get something like this. What we're seeing here is again a thickened bowel wall. Let me just magnify it for you. Not only there is a thickening of the bowel wall in this particular case, but we can also see that the layered pattern of enhancement is very well seen here. What do you mean by the layered pattern of enhancement? You can see that there is hyper enhancing mucosa and the outer layer of the bowel is not enhancing as much. If you see carefully, you can also see some mesenteric changes. You can see fat around everywhere around the bowel wall. So this is something which we can see in early stages of Crohn's disease. One way to differentiate Crohn's disease from TB is the involvement of the IC valve or the IC junction. If you have involvement of the IC junction and the IC valve also starts showing changes, then you're probably thinking about TB rather than Crohn's disease. Now, what will happen next? We've talked about this before also, that because there is going to be thickening affecting the one aspect of the bowel, the other aspect of the bowel is going to show some infolding or outfolding, I should say, over its surface, resulting in formation of the pseudo-diverticulae or pseudo-circulations. Now, in this image, I want you to make out where are the pseudo-circulations or diverticulations. Can you make out? I hope all of you would be now able to say that this is the bowel wall which is thickened, and here you can see that there is a small diverticulum which is extended beyond the confines of the normal bowel wall. You can see this small diverticulum outpouching of the bowel. So this is the typical appearance of the pseudo diverticulations or pseudo circulations that we see in cases of Crohn's disease. I hope you're going to remember this image. So what else can you see? We've talked about Crohn's disease as a mucosal disease, which starts from the mucosa. And when we talk about any mucosal disease which is starting in the mucosa, it is going to denude the mucosa, resulting in formation of ulcerations. Let it be ulcerative colitis, let it be Crohn's, let it be TB. Everything presents with ulcerations. Even we find ulcerations in case of enteric fever. So can we see ulcerations on ultrasound or CT? And we can, but it is very difficult. we use usually barium studies to see ulcerations, or we directly do a colonoscopy for that. So this is a diagrammatic representation in which, first of all, there is bowel wall thickening, which is asymmetric. We already had a look at this pseudosaculations. Over a period of time, you can also see ulcerations developing over the mucosal surface of the thickened bowel. And if we do a barium study, what will happen? This barium is going to get itself extruded, or it will get entrapped inside the crevices which are caused due to ulcerations. If we do a barium study, we're going to get this type of an appearance. If you see carefully what is happening, this is the area of the terminal ileum, and the terminal ileum appears to be thickened, and as a result of which there is significant luminal narrowing, and we can also see some linear extravasations of the contrast on either side. Now, these extravasations of contrast on either side represent nothing but ulcers. Ulcers. And this type of an appearance, as you can see, typically looks like a rose thorn. So it has been given a fancy name, that is a rose thorn ulcers. The other way in which you can also find some other manifestations of Crohn's disease is this. What we're seeing here, in this case, we can see a cobblestone appearance of the mucosa, which occurs because of hypertrophy of the normal mucosal surface which is left. So this type of an appearance, which can also be seen in Crohn's disease, is called by the name of cobblestone mucosa. And this occurs because of formation of pseudo polyps. Pseudo polyps. The ulcers that we typically see in Crohn's disease are called by the name of aphthous ulcers. Aphthous ulcers, again, this is something which we really don't see in our day-to-day life when we do barium studies, because they're very difficult to find and very difficult to interpret as well. Then, once the disease has spread through and through the bowel wall, it is going to go into the mesentery. So when it goes into the mesentery, first thing it is going to cause is an increase in the mesenteric vascularity, something we've already talked about, typical Coombs sign. So I want you to have a look at this image. This is again a CT image of a different patient with Crohn's disease. I want you to tell me whether you can see anything abnormal or not. Let me just magnify it for you. I hope everybody of you will be able to make out the pathology. Pathology is lying here. We can see that there is a loop of gut which is thickened and which is significantly enhancing. And if you see carefully, again, the layered pattern of enhancement can very well be seen. We can see the inner layer of the mucosa enhancing very avidly. Then there is some amount of enhancement which is present in the outer layer, and the middle layer of the bowel is not enhancing as much. Another important thing that you can also see here is the typical Coombs sign, that is an engorgement of the vasa recta, and this engorgement of the vasa recta is typically taking the shape of a comb. So this is the classical Coombs sign that we see when the disease goes outside the bowel wall and involves the mesentery. The other way in which Crohn's can also present is this fibrofatty proliferation of the mesentery. Once the disease goes on inside the mesentery is going to proliferate. There's going to be an increased fatty proliferation, and what we're going to get is this type of an appearance. So this is a very rare case of colonic Crohn's, where we can see that there is some bowel wall thickening. If you see carefully, there is a thickening of the bowel wall, but look at the mesocolonic tissue all around. So all along the mesocolonic tissue, we can see an increased fat proliferation. So this is what is called as fibrofatty proliferation of the mesentery, which can be seen in Crohn's disease, and as a matter of fact, it can also be seen in those conditions which are associated with chronic bowel pathologies like TB, like ulcerative colitis also. Now, this is another diagrammatic representation, and what we see here, the disease has eroded or denuded itself into the mesentery, resulting in formation of fistulas or sinus tracts. How do they look on sonography or CT? As you can see, this is a case which I saw a few years back, and there was this phlegmonous tissue which showed some air foci, and all the bowel loops are closely adherent to it. So I thought that we're dealing with a case of a carcinoid tumor. But the only thing which was odd point for carcinoid is I could not see any vigorous enhancement. I could not see any calcifications. So the patient was operated upon, and this disease turned out to be Crohn's disease. And the reason why we could find a jumbled appearance is because all the bowel loops were now adhered to each other. They resulted in cavitation, and there was an escape of air outside the bowel lumen into the mesentery. So if you see this type of a, again, the speculated appearance in the mesentery, obviously the first thing that you should think about is a carcinoid. But if you don't see the typical avid enhancement, if you don't see the typical calcification in the central part of the lesion, then probably you're dealing with Crohn's disease. Finally, let's come back to our case. Why do we have obstruction? Look at this particular image. If you have bowel wall thickening, which is causing luminal compromise, then it can result in formation of strictures. So what we're seeing here is we can see a long segment bowel wall thickening. So I can't call it a stricture, but because there is luminal occlusion, luminal narrowing, you can see dilatation. So this is another way in which Crohn's disease can present. And mind you, a very important thing in case of Crohn's disease is once you have stricture in a Crohn's disease, there is always a risk for multiplicity. Multiplicity. The strictures can be multiple, can affect multiple segments of bowel, and this thing should be known to the surgeon because once he keeps on operating this patient, there may be many new number of strictures that might pop up during surgery. So, with this, we finish our comprehensive discussion on Crohn's disease.